So it looks like we have time for a couple of questions. Yes? Yes? Got the nod? While people get ready to line up to the microphone, I'm just going to ask Gary and Marcia, and Gary, this is very unfair, but I did warn you. We've heard from some brilliant folks about some, not the ideal tools, but a lot of tools that can be brought to bear to help improve the health of people with obesity. And yet we've had a theme all day long of really abysmally low utilization. 2/3 of employees with obesity have never, ever been treated for obesity. CMS has a benefit for intensive behavioral treatment that 0.6% of the target population have received. How do we close that gap?
You did warn me. I'm not sure I have quite the answer, but I'll take a piece of it. I'll take my little slice of the elephant. I'm a software programmer by avocation, and I tend to think about the user when we're creating our software applications. And so, if I were to apply that same window here, that same lens here, I'd say, gosh, if we think it's complicated and fragmented and doesn't make sense, imagine what our patients are dealing with. I don't know how we can expect patients to advocate for themselves given this set of this scenario. And we've made it really hard for patients because we call obesity a disease, and indeed it is, but in fact, the lack of attention to obesity, specifically in the primary care setting, undercuts any of our efforts, in my view, to try to help patients to realize the clinical significance of the condition. So if I were to try to attack any place, I'd be squared in as much as possible in the primary care setting. I think we need to do everything we can to ensure that that primary care providers have the simple tools to be able to do the three things I think they do particularly well, and that is to screen, to stage, and to hold patients accountable. I think one of the mistakes we've been making in this space is expecting primary care providers to do a lot more than that. I think we can very easily equip providers to be able to take a BMI and present a range of options. We can use very simple electronic tools to help patients and providers to undergo a very brief shared decision-making process, and have that provider drive it home and hold that patient accountable. I think that would do wonders. That's low-hanging fruit.
Marcia?
Sure, so thank you. There were so many answers to that question that I think bubbled up today, building on what you said, because I do think primary care is a good place to start and the appropriate role for the primary care people. So they don't need to be delivering the full intervention or the full program, but they have to recognize it exists, be identifying the need, doing that matchmaking, assessing whether this person is ready to address what's going on. We talked about the provider education side of things, the top down, the bottom up that needs to happen. I think the design of the program, it's all full disclosure because, our association is a big advocate for the Treat and Reduce Obesity Act because we say, I don't think Medicare got it right in designing it. So to us, is it a surprise that there's low utilization? Not really. So I think that is that, we have to be person-centered. We have to take these ideas in theory and do a better job of figuring out what's the policy, what's the procedure, what's the implementation that really brings the person into the question, the provider perspective into the question, all this, the payer perspective, obviously that's important, but I think we lose sight frequently of, like what I said is the need versus the true demand. And perhaps the utilization is low because we really didn't pay enough attention to how we designed these things and whether people are really ready for it or it's designed in a user-friendly way for them.
Please identify yourself.
Dave Fukazawa, Kresge Foundation. So thank you both. This is a question for Gary, because as people on the, I'm a member of the roundtable, as people on the I think we're calling it Eduardo Community Clinic Integration, IC. No, I've become a great fan of new technologies and stuff like that. And we've actually supported some of the investments in this area. But one of the things that I've been curious about is not only how the data can be gathered, and exciting to hear that you're looking at this for clinical interventions, but use of that data sort of at a community or population level to begin to target community level kinds of interventions. So I'm just wondering how, if you're seeing anything in this space and what's happening, if anything.
Not as much as I'd like to. No, I share your interest in the topic. We're seeing. I'm not seeing individual level data aggregated to be used on a population basis. Certainly, we're seeing sort of more spatial data used in that way to identify hotspots and pockets of risks and identifying food deserts and those kinds of characteristics. Now, we happen to use data like that in our tools to try to help do a better job at treating our patients. So, for example, we like to know when our patients live in areas where they may have impaired access to fresh fruits and vegetables, and then we'll make accommodations in our technology to ensure that those patients get a certain set of goals that will be more supportive of them. But we tend to think about it that way, using the spatial data to better inform our clinical care. I have yet to really see great examples that come to mind immediately of the opposite.
I'll offer an answer to Ted's question, how do we get more people?
So identify yourself first.
Bruce Wolf, bariatric surgeon from this morning. The problem that we have in clinical care is that we put all the people with obesity in one bucket. We've talked about what a heterogeneous condition it is today, but the primary care providers or surgeons or other therapists don't really have a basis to tell a specific patient how much risk they are at for developing an obesity-related condition, such as obesity-related cancer, which we haven't heard much about today, but there's a subset who are likely to get breast cancer or endometrial cancer, which is the highest risk obesity-related cancer. If we could tell a given patient that you are at risk for developing a specific endpoint, that would have a great impact on their interest and motivation to enter the healthcare system about their weight. And we've heard today about how there's a problem that many of the patients who are affected by obesity don't really believe they have a serious health problem, and that's why they're not seeking care. And from the provider side, we in fact don't know how to match patients with the optimal intervention for that patient. We heard this morning a dazzling array of devices, medications, new concepts for pharmacotherapy, as well as operative procedures, variable risk, variable efficacy in weight loss. We don't really know how to match patients with the treatment. And what we do in surgery is the patient has a BMI, we give them all the same intervention. But that isn't really focusing where we need to be. So I believe we need more detailed research in order to better characterize the disease risk that the patients face, as well as make better predictors of outcomes from intervention.
Don, are you going to send everybody home?